move on to looking at CMS scrutiny and compliance issues. This is directly from CMS slide deck from May of last year. It was the Quality Reporting Program provider training that they provided. And here it basically says, given the more holistic style of care emphasized under PDPM, program integrity and data monitoring efforts will also be more comprehensive and broad. For program integrity, we expect provider risk will be more easily mitigated to the extent that reviews focus on more clearly defined aspects of payment, such as documentation supporting the patient diagnoses and assessment coding. I don't know how much clearer they can get in terms of what their intentions are as to how they're going to watch as we transition from a RUG model to a PDPM model, how they're going to be monitoring this transition, right? It's about program integrity, and they're going to be, they're basically saying your risk will be easily mitigated by documentation, right? So, again, if you get nothing else out of this session today, it's about going back and seeing, do you have any of these red flags? Does your data look like the data I shared with you just a moment ago? And do we have the documentation to support those changes in our coding? They're pretty dramatic changes. So where is the documentation to support that coding? Okay, and CMS clearly does not want to have a repeat of the RUG model issues, and I think it was John Kane that kind of called it that the RUGs model had somewhat of perverse incentives for that kind of for coding of those minutes, and we know that there were challenges with that in certain areas, and so we have to protect ourselves and make sure that's not what most providers are doing, but it certainly can appear that way in the absence of that documentation. Okay. So again, I underlined that last line, documentation to support the patient diagnoses and assessment coding. So, what if your data looks like the national averages? Everyone's data does tell a story, but you have to ask yourself, is it the right story? It's just like you can watch news on 3 different news outlets, and you can hear the same story, basic story, based on the same data or the same information, but you hear 3 different spins or 3 different perspectives on that same story, right? And so, we all know with our data in terms of how we're looking at it, and we think it's one way, but when we're looking at it through the lens of CMS, who's concerned about repeating of the prior RUGs model, they're going to be looking at it through the lens of much more focus and perhaps more sinister thoughts about what story your data is telling. And so you look at your data and look at the story that your data tells, and do you have the dramatic changes? And if so, why the dramatic changes? So let's consider the cognitive impairment and the depression changes. So just in those 2 areas, these are 2 areas that are specific to the resident interview process, right? And so, is it that we are truly really seeing more cognitive impairment than we did in Q4 of 2019, or excuse me, that would have been Q3 calendar quarter, right, of 2019 versus Q4 of 2019? I mean, that was a pretty dramatic jump. Are we seeing different patients? Where most likely that's not the case, but what is? Did we change who was doing the interviewing process, right? A lot of folks talked about changing up maybe a little bit, that might be a good thing. Did we change it? Did we provide extra training on interviewing? Did we really do just an out and out, all facility or corporation or organization-wide emphasis on better interviewing techniques, right? Certainly a logical explanation and a very, very valid reason why you might see an increase in that, Okay, we know it's going to be important. So I think CMS is expecting to see some of this legitimately. And now that it's a driver, that maybe these facilities will pay more attention to it. But it's also about quality of care, right? Because recognizing cognitive impairment and recognizing depression means better interventions on our care plan, right? That we're hopefully going to address the care concerns part of it as well, right? So they're going to be looking at care plans. We should be looking at care plans. They're going to be looking at your interview process. So you need to take a look at the interview process. I know here at PointRight, as we evaluate some of the things that come through on our data integrity audit, and we get a lot of questions on our help page where people are always asking, I don't understand why this triggered. Well, what we're seeing is, are we seeing an increase in the number of staff assessments being conducted where there's also a resident interview for a different component? So perhaps their pain was done as a resident interview, but yet the staff assessment was done for the cognitive assessment and maybe the depression symptoms. Okay, so why is that? If they're interviewable for one, they should be interviewable for all. And so it's really important to look at your process. Has your process changed? Is it for the better? Is it, are you really capturing it? Or is there evidence of maybe somebody just kind of getting in there and doing a bunch of staff assessments, which might be easier to get them done? Or perhaps during COVID, you made changes to how you're doing it to decrease the contact, the number of different people that residents had contact with, and now you're seeing an increase. Again, these all could be very legitimate reasons, but they certainly, if you're seeing these changes, this is where further investigation is definitely warranted, okay? So again, so when you look at this and you see these changes, are you investigating the coding, and are you documenting your research and your investigation and your analysis as part of your QAPI? A lot of times when these ADRs and possibly even these federal surveys or even inspections for potential fraud come through, these are, months and years later, right? And so you need that documentation. Nobody can commit that to memory and understand why these occurred. So again, this is really important to make a part of your QA API process overall. Along the same lines here, same goes here for swallowing disorder and mechanically altered diet. If there are dramatic increases here, again, is it a better process for assessment, a result of increased training? Are you seeing more certain types of residents? Again, this could be possible, certainly, in the latter quarters related to COVID. Maybe we are seeing some changes in the types of residents we see. We know there's been a decrease in admissions from the hospital, decrease in elective surgeries. So surely this is a legitimate, potentially a legitimate explanation for this, but you don't know until you get in there and look. And again, making sure you're documenting this. You've got the documentation to support the coding and the documentation to support your analysis in your QAPI. Okay. So again, let's look, how has COVID changed your data story, right? Have you seen dramatic increases in extensive services? So here I would say, did you code your isolation correctly? There was a lot of questions out there about how do we do this if we're cohorting residents? What if we don't have a positive diagnosis yet, but we have a presumptive diagnosis? And, there's definitely a presumption of COVID according to the physician. If we have this documentation, is that enough? Bottom line, I mean, again, this is definitely a question that a lot of folks have had. And I think right at this point, what we have in writing is the RAI manual. And so very important, sticking to the strict coding isolation. We know that we've heard that the cohorting is not a legitimate way to code for extensive services, So again, go back and look and making sure, especially early on, if perhaps you changed how you were doing this coding, do you have any that might be coded incorrectly that you need to address, okay? Or at least document and make sure that the explanations are there. Let's take a look at areas of risk for increased scrutiny in your outcomes. Okay, your quality measures might be telling a different story than you think they're telling, right? And so again, looking at your quality measures routinely, and I know you're challenged with time, with so much going on, but if you can take a look at some of those quality measures, and again, looking at whatever system you use, hopefully you can get in and take a quick glance and see what's happening here. Because one of the things that CMS has very clearly mentioned is that yes, we expect that there probably will be some changes in therapy delivery, but we're going to be watching your outcomes, right? And so looking at this is just one example of that I found in facilities data. And looking at this is the short stay improvement in function quality measure. Okay, and so you see in September, October, November timeframe, they were doing really, really well here. This is an improvement function, so higher is better, and so they're well above the national average, 89.8% for their rate and 69% for the national average. Well, then what happened? In December through February, that tanked. It dropped dramatically to 65.3%. So again, this was pre-COVID, right? And so say, okay, well, what happened? Well, again, in your mind, you're thinking, well, maybe you can explain it one way. But I'll tell you, one way CMS is going to look at this is they're going to say, I wonder if this facility changed how they were delivering therapy services because it wasn't necessarily the payment driver anymore. And they switched over to group and concurrent therapy more, and they dropped the number of minutes that they were doing per resident, just because it wasn't that important anymore, right? I mean, again, that could be the kind of the dark side that CMS might go to, just looking at this data. And again, until they get in there and evaluate, they're not going to know for sure. But again, they might start pulling and saying, we're going to evaluate, and this is a facility we're going to dig into and scrutinize a little bit more carefully. Okay, so again, this is why it's important to be looking at. This was pre-COVID. Okay, right there, you can see the drop. And again here, we've got to understand the changes in your outcomes. Here is the Medicare 30-day rehospitalization measure. Okay, and again, this facility might not be too concerned because they're below the national average. This line up top here, this blackish line here, is the PointRight national average. And you see the facility observed and the facility risk adjusted lines are well below. Okay, again, but what you see here in February through May of 2020, you see this really gradual upward trend, and that's not necessarily a good thing. And so you want to watch your trends over time, even if you're below the national average, because then very quickly those things can jump up, and get you, catch you unaware, right? And so paying attention is really important, even to those subtle changes. Okay. And and what impact? And I think we're just scratching the surface right now. What impact is COVID-19 going to have to the quality measures, right? We know 5-star, definitely CMS has done the freeze for us in certain ways. That's certainly going to help. But again, once that starts opening up, what's going to happen? But we have got to look in terms of on a month-to-month basis. And again, if you're looking at more real-time quality measures, this is where it gets very, very helpful. And let's be very vigilant, especially on areas of depression and mood disorders and behaviors. That social isolation that we're all going through, but specifically our residents, we're at much more increased risk for this. And then also you could say, if we're starting to see more mood disorders and behaviors, are we at risk for seeing more use of antipsychotics or psychoactive medications, right? Risk for decreased mobility, pressure ulcers, incontinence, weight loss, falls, all of the above, right? And so I think this is what, one thing that we have to be very, vigilant on, and looking at MDS accuracy. Make sure you're using your data integrity auditor, your MDS scrubber if you've got one, making sure that everything going out, one MDS at a time, is accurate. proactively monitoring your quality measures, and looking at, possibly did you have other staff helping with MDS during the outbreaks? So this might be even more reason to make sure that you're reviewing each MDS for accuracy very, very carefully. Okay. And again, even if you weren't impacted by the number of folks in your facility that had the virus or have the virus, your residents are certainly impacted by the precautions that they're taking. And I can't even imagine, not having, those family visits. And so we're very, very likely. And again, I think we're just seeing the tip of the iceberg here.